Multimodal preoperative optimization of severe loss of domain incisional hernia using botulinum toxin A and progressive preperitoneal pneumoperitoneum. Severe incisional hernias with significant loss of domain remain one of the greatest challenges in abdominal wall surgery. Restoring abdominal domain while avoiding tension, respiratory compromise, and abdominal compartment syndrome requires careful preoperative planning. In this video, we present a multimodal preoperative optimization strategy combining botulinum toxin A and progressive preperitoneal pneumoperitoneum in a patient with severe loss of domain. Patient and preoperative assessment. We present a 56-year-old male with a massive incisional hernia following emergency laparotomy for spontaneous neobladder perforation. Preoperative computed tomography demonstrated a facial defect of 13 centimeters and a large hernia sac measuring 17 by 11 by 20 centimeters. Volumetric analysis using the Tanaka method revealed a loss of domain of 51%, indicating a very high risk for incomplete or tensioned facial closure. Rationale for multimodal optimization. In this clinical setting, primary repair or isolated component separation carries a high risk of postoperative respiratory failure, abdominal compartment syndrome, and wound-related complications. Therefore, a multimodal prehabilitation concept was chosen to increase abdominal wall compliance and intra-abdominal volume prior to the definitive reconstruction. Botulinum toxin A injection. Under ultrasound guidance, 200 international units of botulinum toxin A were injected bilaterally into the external oblique, internal oblique, and transversus abdominis muscles. The goal of this chemical component separation is temporary flaccid paralysis of the lateral abdominal wall muscles, allowing medialization of the rectus muscles and progressive elongation of progressive preperitoneal pneumoperitoneum. A subcutaneous port was implanted to enable progressive preperitoneal pneumoperitoneum. Daily insufflation of 1,000 millimeters of air was performed over a period of 14 days. This technique gradually expands the intra-abdominal volume and improves physiological adaptation, reducing the risk of acute postoperative pressure-related complications. Definitive surgical planning. After completion of the prehabilitation protocol, definitive open abdominal wall reconstruction using a sublay technique was planned. The achieved preconditioning enabled tension-free facial adaptation under optimized anatomical and physiological conditions. Key learning points and conclusion. In patients with severe loss of domain incisional hernias, multimodal preoperative optimization is essential. The combination of botulinum toxin A and progressive periperitoneal pneumoperitoneum improves abdominal wall compliance, increases intra-abdominal volume, and facilitates safe definitive reconstruction. This structured and reproducible approach represents a valuable strategy for complex abdominal wall surgery. Key learning points. Severe loss of domain requires preoperative volumetric assessment. Botulinum toxin A improves lateral abdominal wall compliance. Progressive pneumoperitoneum increases intra-abdominal capacity. Multimodal prehabilitation enables safer, tension-free reconstruction.